My name is Dino Plastis, and I'm the director of Jefferson Aortic Center. And it's a great privilege to be the guest editor in a wonderful series on the surgical management of acute aortic dissections. I will give a few more seconds for people to log in, and we're going to start very shortly. It's very interesting that this series started, the idea of that series started by Joel Dunning, whom I thank him for that. We were in a meeting together in Moscow approximately a year ago, and he came with this wonderful idea. Taking that opportunity, I would like to thank Catherine Joyce and her team. They did a wonderful job to put all of us together. And of course, I would like to thank the staff at the CTSNet for working hard to make that happen. I would like you right now to introduce you the agenda. Of course, we had excellent videos by all the participants. They presented a lot of aspects of management of aortic dissection. Of course, there are a number of things that can be that will be discussed in this webinar. And that being said, I'm very happy and privileged to have with us Josh Green from the University of Pennsylvania, Roland Assey from Yale, my friend Ibrahim Sultan from University of Pittsburgh, Chris Malayser from Northwestern, and Derek Brinster from Lenox Hill Hospital. All of them are great aortic surgeons, and they represent different schools of thinking. And I think that will give an opportunity to all the participants in this webinar to listen what the experts are saying. Josh, if you don't mind to start and introduce yourself, and then we'll go to Roland.
Yeah, good morning. Joshua Graham. I'm a faculty at the University of Pennsylvania. I do complex aortic surgery from Texas originally.
Roland.
Hi, good morning, everyone. I'm Roland Assey. I'm on faculty at Yale. I'm one of the surgeons at the Yale Aortic Institute, and we perform complex open and endovascular aortic surgery here.
Ibrahim.
Yeah, thank you again, Dinos, for having us. My name is Ibrahim Sultan. I'm an adult cardiac surgeon and aortic surgeon at the University of Pittsburgh Medical Center, and I oversee the Center for Thoracic Aortic Diseases at UPMC.
Excellent. And Chris?
Hi, I'm Chris Malayser. I'm a cardiac surgeon at Northwestern Memorial Hospital. I'm professor of surgery at Northwestern University.
Derek, I'm not sure if he's on. He's finishing his surgery. He just called us to let us know about that. But if he has not logged in yet, I'm expecting him to log in very quickly. That being said, I would like to start the discussion. And as I said, we had wonderful videos, very nicely done by all the participants. But I would like to start that discussion with a very simple question. A patient comes with a type aortic dissection, and you get a phone call from an emergency room. How do you handle the transfer? I mean, these people are quite sick. They have either hypertension or hypotension. What do you instruct? How do you instruct the emergency room physicians as to what to do, and what do you do with the transfer? We'll start with Josh.
Yeah, it's a great question. I think it's critical to get these people to your institution promptly, while at the same time ensuring that they're safe, in the interval time period, and that they aren't sort of forgotten about at the outside hospital. So usually we like to talk to the physician taking direct care of the patient, so there's less, telephone, so to speak, and more direct communication. We like to get a little bit more about the past medical history of the patient, what kind of comorbidities they have, how they presented, how they're doing currently, what kind of drips, if any, they're on, and their current hemodynamics. And usually you can get a pretty good idea, like a broad brush stroke on how the patient's doing. You'll give them some insight about blood pressure management. A lot of these people are hypertensive at baseline, and they require, it's sort of a complex issue because they require perfusion pressure to the brain. And sometimes their coronaries, while at the same time the aorta is the main issue at hand. So we like to keep their blood pressures, less than 120. And a lot of these institutions will not place A-lines before transfer. I don't think it should slow down the transfer. And I think it's key at Penn, we bring these folks directly to the operating room. We don't delay by taking them to the ICU unless there's some special circumstance. They bring their imaging with them as well. It's critically important for us to see the nature of the dissection, any aneurysmal disease in the ascending or arch, and what their access vessels look like.
Ibrahim, in the same topic, do you take the patients directly to the operating room, irrespective of what the issue is, or you take them to the ICU, try to see what's happening with the patient, and then based on that, take them very quickly in the operating room?
Yeah, I think, Dinos, that's an important point. So I think, as you said, there's different school of thought, and we operate on everyone, including malperfusion, including cerebral or visceral malperfusion. So the way it works is, we have a fairly large system. We have 42 hospital systems. So, and even outside of that system, as soon as we get a phone call, the helicopter's already on the way to that ER, even before we get the referring doc on the phone with us. So they're already there. They're picking up the patient, essentially. So that's automatically there. So the only difference is we get the information. So if it's a type aortic dissection, which we know, and we can look at the films remotely at times, they fly in directly to our operating room. And so at that point, everyone gets activated, the entire team.
Roland, what is the feeling at Yale? Let's say you get a patient who they tell you that he's comatose, for example, has type aortic dissection. 85-year-old person. Let me give a very simple example, because these are the common things that we face as an aortic surgeon. 85-year-old who is comatose, has a type aortic dissection. They manage him in the emergency room, and then they call you. What do you do with that patient? Do you take him directly to the OR? Do you evaluate him in the OR? Do you take them to the ICU? How do you handle that situation?
So in general here, our philosophy is, the moment we get the phone call and we have a very good referral central Yale access, by the time we hang up on the phone and if we hear dissection, aortic dissection, the OR has been alerted and transport is being arranged. And we, in our mind, would like to actually confirm or, make the diagnosis in the OR rather than trying to figure out over the phone. And occasionally we have this patient who shows up and has a, very stable type B dissection. It's not a type A. That's fine. Everyone goes back home and, we manage the patient appropriately. But we have no, no one that is turned down from surgery. And for some patients that, if for some reason, if we talk to the family and, there's a decision not to proceed with surgery, we'll make the decision on the operating room table before making a decision. So we don't really put any delay. Now, one thing that, was a little bit of a challenge was during COVID, but where to take these patients when there's an unsure COVID diagnosis. And what the hospital was very good at doing here is quickly transforming a couple of the operating rooms right now that could be a COVID compatible, if that's a good word to say, for cardiac surgery. And for patients who don't have a COVID test that has resulted, we treat them as if they have COVID, and we put them in a COVID room and we do the operation as if they have COVID. So that didn't cause major delays neither.
I'm glad that you answered that question. Actually, this was the question I was planning to ask Chris. How do you handle patients in the COVID era? Because, it takes a couple of hours to get the COVID test back, but an emergency type aortic dissection has to go to the operating room. What is the feeling at Northwestern, Chris? How do you handle that situation? And how do you handle overall type aortic dissections?
Well, type aortic dissections, time is life. So we have to get the patients in the operating room as soon as possible. For our program, we've taken lessons from our friends at Penn and Pittsburgh. We also instituted a direct to OR protocol, and we found that we can cut a good 70 minutes off as opposed to having the patient making a pit stop in the ICU. COVID has posed some challenges for these rapid protocols, but there's some tricks you can do. We always insist that the COVID test is done at the ER. So by the time they get to our hospital, we at least have a sense. We treat patients in 3 fashions. Either we know for sure they're not COVID, in which case we follow normal protocols. For indeterminate cases, we treat those patients as if they had COVID. So everyone wears PPEs, and there's staging areas outside the OR to decontaminate. So we do take it seriously, but we have not found that to be an impediment to treating our patients with acute type A aortic dissections.
Now, I think the consensus, and I agree, I think the consensus is get the patient to the operating room as soon as possible, make the diagnosis and take action in the operating room as fast as possible. Just to inform the participants, you know, they can do questions, and Jackie McGee is next to me here, and she will ask questions, and I will ask her to ask the first question.
Hi, so we have William Wang, and he said the biggest concern is pericardial effusion and the patient's neurologic status. He said, you know, there's no use going to surgery, obviously, if their neurologic status is poor. Any comments for that?
Actually, it's a good question, and it is my next question, because okay, we have a type aortic dissection. We know that's an emergency. We know it has to go to the operating room. Majority of them, they have no malperfusion, but there are patients who have malperfusion, particularly gut and brain, or peripheral, you know, like lower extremities. How do we handle those patients? And I want to be specific about that. Again, you have a 70-year-old patient. He comes, has a type aortic dissection, and he has a stroke, and it's pretty significant. Or he has evidence of bowel ischemia. What do we do with that? Michigan believes that some of these patients we should wait in some of those patients. So to start again from Josh, significant malperfusion with symptoms. It's not only a radiographic finding, but you have symptoms. How do you handle those, particularly gut and brain ischemia?
Yeah, I think the Michigan group did a really great job at separating sort of malperfusion, whether it's dynamic or static on CTA, and then a malperfusion syndrome. So not just radiographic signs, but marrying that with clinical stuff. So elevated lactate, severe abdominal pain, things of that nature, or a profound stroke on exam. I think it really gets to take the whole patient into consideration. If you have an elderly patient, 70, 80-year-old patient, we actually had this overnight, with profound neurologic deficits and multiple comorbidities, I think you have to have a realistic conversation with the family regarding their potential outcome. We know patients going into the OR with a devastating stroke prior to type A repair do not fare well. And so I think being really open with the patient's family is critical. The other thing is to really tease out, do they have a neuro exam before they're intubated, if they're intubated? And then if you have any radiographic imaging of the head to see how devastating the stroke is. If patients come in with malperfusion just on a scan to their brain, but clinically their deficits are minimal, we would still proceed to the operating room for a proximal repair. Extreme gut malperfusion, maybe one of the other panelists can weigh in as well, but gut malperfusion with lactate above 10, severe abdominal pain, and perhaps fluid in the abdomen if it's a delayed presentation, those patients are not going to do well. The Emory group does upfront TVARs to increase true lumen flow, and as you mentioned, the Michigan group does fenestration with selective stenting. So those are options, because we know that those folks going straight to the operating room usually have bad outcomes.
So Ibrahim, to be very specific, so the patient is hemodynamically stable, but there's no pericardial effusion, maybe moderate AI, and severe gut malperfusion with gut ischemia. Do you take him to surgery to fix the gut? Maybe you have to take some of the bowel out and stabilize the situation. Do you do an angiogram? How you would handle a patient like that?
Yeah, I mean, I think again, it's a tough situation, but this is something we see not infrequently. So I think unless it is, I think two things. If it's specific gut-only malperfusion, I think that's relatively easy to go after. But I think if this is a combination of an absent femoral pulse with, essentially a dead leg, a dead gut, and a stroke, that's 3-bed malperfusion. That's almost an 80-90% mortality. But if it's specifically gut-only, I would most likely operate on them. Do a proximal repair, and then do a laparotomy to see if anything needs to be resected, especially because these patients will come in relatively early on in the course. Now, if this is somebody who's been in a nursing home for the past 5 days and has essentially, cat's out of the bag, that's a very different story.
Roland?
So I agree, these are high-risk operations, but in general, we still offer surgery. And in our experience, actually, we've had more type A dissection with multi-organ malperfusion than type A dissection without significant malperfusion here. And almost all these patients had full recovery. I think the key is the duration of the malperfusion syndrome more than anything else. And even with a patient, the most recent one we did a few days ago had a stroke, with dense deficit on one side of the body, had an acute limb ischemia, one kidney that was out with acute kidney injury, and altered mental status. And we still believe in the basic principle of true lumen perfusion as soon as possible. So we basically just take the patient to the OR, put just the necessary lines, open up the chest, and go on bypassing the true lumen. And for the most part, if these patients were diagnosed in an ER and transferred immediately to us, we're having very good result reversing the injury. That's different if someone who's at resting or completely in a comatose state who has had symptoms for many, many hours and has been undiagnosed. Obviously there, I think, an opportunity has been wasted.
I see. Chris?
I agree with everything that's been said. I think malperfusion is a difficult syndrome to manage. For stroke, I would say give that patient a chance, especially if you could get them early. I think 6 hours within the onset of neurologic malperfusion. I think it's a very reasonable time frame to take the patient to the operating room, and you can often reverse some severe cerebral malperfusion. Now, for leg ischemia, we also take them directly OR. At the same time you're doing the type A dissection, you can also do procedures to reperfuse the leg. You can do a fem-fem crossover bypass. You can also put a perfusion cannula in that leg that's malperfused. I think bowel malperfusion is the hardest one to manage. I think if it's just malperfusion and ischemia, we'd take the patient directly to the OR for a definitive type A repair, restore blood flow in the true lumen. But if it is in fact infarction, and sometimes you can tell because you got a CT scan, if it is an infarction, then maybe by some groups, Michigan being the prime group, that would be a group of patients that you would not take directly to the operating room.
Yeah. I think one has to individualize. I agree with you. And as long as we want to be aggressive in management of these patients, we have to realize that some patients cannot be salvageable. The disease is a very lethal disease with a very high mortality rate, even in the 21st century. So one has to use judgment, and particularly in elderly individuals with multiple perfusions. Let me go to a very important topic. And I will connect two questions here. Cannulation strategy, and of course there are pros and cons in everything, in association with hypothermia, moderate or deep. I don't want you guys to go, you can go plus and minus for everything. But starting from Chris, what is your cannulation strategy and what type of hypothermia do you use? Do you go to moderate degree, you cool down? What is your feeling about that?
For most of our patients, we do axillary artery cannulation. We think that axillary artery cannulation is the best way to do antegrade systemic perfusion. And also, it gives you the ability to do antegrade cerebral perfusion. When we do antegrade cerebral perfusion for circulatory arrest, we do moderate hypothermia. And I think the data bears out that axillary, compared to femoral, has a better mortality rate and better stroke rates. The reason I do that is because with axillary artery cannulation, we're prepared for any sort of surprises that we find during the operation, mainly meaning that if we have to do a total arch operation, then we're ready to do that. So it gives me the most flexibility to manage whatever we find in the operating room.
Roland, what do you think?
I pretty much agree with Chris. However, I must say that our preferred cannulation is still direct aortic cannulation with wire in the true lumen with TEE. However, more and more we're kind of moving towards axillary cannulation just because it's such a nice stable platform and very versatile. You can really do a lot of the operation that is simplified because of the axillary cannulation. The one thing that we almost never do is femoral cannulation. We feel that it's a little bit unpredictable what you're flowing and what you're perfusing with femoral cannulation, but pretty much our go-to is central cannulation directly with a wire or axillary cannulation.
And what about Ibrahim? What do you think?
Yeah, I think the fundamental point, as Chris pointed out, I think antegrade perfusion is key to reduce stroke. But our default is central cannulation virtually for everyone, unless there's a large enough circumferential or primary arch tear where you can potentially make that worse. So our standard protocol is direct central cannulation. We think it saves some time. And typically we use an arch first technique in most of our patients. So as soon as we start sewing the arch vessels, we sequentially use cerebral perfusion that way. So, but that's been our standard.
And Josh?
Yeah, I don't have much to add. I think something that Ibrahim just touched on was, and maybe Ron as well, is it depends on really the status of the patient. If the patient's unstable, axillary cannulation is great for zone 2 or total arch, because you can just transfer right into an ACP platform. But if they're unstable, if they've got a big effusion, if anesthesia is having a hard time keeping their blood pressure up, I think getting true lumen flow as quickly as possible with direct aortic cannulation with a wire in the true lumen under echo guidance is great, because then you really pressurize that true lumen. And if you do have sort of a quasi malperfused state, that gets all remedied pretty quickly.
We're going to have we have the ability to do polls, so we're going to send a poll to launch a poll on what people believe on moderate hypothermia versus deep hypothermia. So please try to do the best you can to see, and we're going to share those polls, in a little bit. But to continue to the same question, I have to admit that people have to feel comfortable, particularly in an emergency. So what is whatever makes you very comfortable in cannulating, and again there are pros and cons in every type of cannulation. It's important to do, particularly for non-aortic surgeons. If you feel comfortable with the femoral cannulation, please do that. If you feel comfortable with subclavian, do or direct aortic cannulation. We have to recognize that the experience plays an important role in all this, and that is why safety is an important part when surgeons, even aortic surgeons, do that. By the way, moderate hypothermia, almost 72%, and deep hypothermia 28%. So moderate hypothermia is winning everywhere. I'm a little bit of an older school. I like deep hypothermia, but this is what it is. Let me ask you something. Brain protection obviously is very critical to that. What about antegrade versus retrograde cerebral perfusion? And I would like to start with Ronald. I mean, Yale in the past used to do only deep hypothermia without any adjuncts. And deep hypothermia is not bad, by the way, it's great. But what is the current way of thinking in terms of hypothermia with RCP versus ACP?
Okay, that's a great question. So things have changed at Yale. Everyone will have their brain perfused in a way or another. In terms of the degree of hypothermia, I strongly, and we as a group strongly believe in deep hypothermia for everyone with type A dissection. And the reason is not just for cerebral protection, because we can always perfuse the brain, and the brain, you can perfuse it at normothermia, it's fine. But it's protection of the rest of the body, including the spine. And I'm saying this because when you plan for a deep hypothermia and you go on circle rest and you find that you have to do much more work than you expect, if you cannot cool anymore, whatever temperature you are, And we're very liberal at dropping antegrade TVAR, what we call a frozen elephant trunk, in these patients. And there is an increased risk of spinal cord ischemia and we think that the deep hypothermia actually helps with protection of the spine in these cases, in addition to other technical aspects like the size and the length of the stent. So we think that the safest approach is deep hypothermia. In terms of perfusion, we employ RCP and antegrade cerebral perfusion in almost all patients with complex reconstruction that need more than just a hemiarch reconstruction. Usually for a circle rest time less than 35 minutes or 40 minutes, we think that RCP is probably good enough in conjunction with deep hypothermic arrest. For anything that's going to take more than a hemiarch, or in other words, more than half an hour of reconstruction, we start with RCP until we debride the aortic arch, and by the time we're starting our reconstruction, we switch to ACP.
I see. What about Sultan? What do you guys do with that?
Yeah, Dino, so it's the same kind of philosophy. Our default operation is a zone 3 total arch with a frozen elephant trunk. So that's our default type A operation. But if we were to do a hemiarch, we would use deep hypothermia with RCP. Anything, if we were doing a total arch, that's, we do integrate cerebral perfusion, bilateral, with using ACP. And we use deep hypothermia. And I think even though moderate is trendy for aneurysmal surgery, there are no data necessarily, to show that it's superior in any way. In fact, most of the prospective randomized data that's come out of aneurysm surgery that Brad Leschnauer did using MRI data shows that ACP has a higher embolic event. But having said that, for longer periods of ischemia, I think antegrade is key. But we definitely do not hesitate to cool.
I think that's great. One point I want to make, particularly for people who face that emergency in the middle of the night, and they are not aortic surgeons to be able to handle all the circumstances, deep hypothermia gives you a little bit of safety. And please do not hesitate to do that, particularly as Roland said, you may face a problem that you are stuck now and you cannot do any more hypothermia. I have a lot of questions here, and I'm glad that Jack is next to me because I don't know what I will do with all this, but very nice questions. And I want you to give me yes or no. Yeah. Like, for example, the question is, what you would do for a patient with previous cardiac surgery and aortic dissection? Do you take them to the OR directly, or you work them up in the ICU first? I don't want you guys to elaborate. Do you take them to the OR, or you work him up a little bit more? Because that's a special circumstance. Chris.
Yeah, the issue with reoperative surgery, you have options, especially if the patient has had a previous coronary artery bypass grafting. I think it's worth it to take the patient to get some additional imaging of the coronary arteries. You could take him to angiogram. However, if you get a Marfan patient who had a previous mitral valve repair and now has a type A aortic dissection, there's really no reason to wait for that patient. We take that patient directly to the OR.
I agree with Chris, and I don't want you guys, I don't have enough time for everybody to answer, but I think Chris's answers exemplifies what to do given different circumstances. All patients with type A aortic dissection, strong family history of coronary disease, no malperfusion, hemodynamically stable, coronary angiogram pre-surgery, all patients, strong family history. Let's say normal LVF, left ventricular ejection fraction. Do you take that guy to surgery? Roland, what do you think? It's an interesting question.
Yes, great question, but we almost cast no one with a dissection. Actually, that'll be amazing if you find a cardiologist who's willing to put a catheter in a dissected aortic root. But the other answer is, you do the operation, and if you have any abnormalities on the echo coming off bypass, we just bypass the territory.
What about if you do a CT coronary angiogram? That's an option, that may be an option under those circumstances, So
that's an option for patients who got a CTA that was gated at the first time, but I would not repeat a CTA within hours just to look at the coronaries.
The coronaries. Ibrahim?
Yeah, I agree with that. We don't cath at all. If the CTA allows, if for some reason they get a gated CTA, we look at the prox cores, and we've gotten pretty good at that just because of TAVR CTs and things, to kind of judge how tight those lesions are. Uncommon to cath them before. Yes. I think it's just wastes time.
Yeah. Let me ask you one question, a very interesting question. What do you do with the patient who arrests on the table before prep and drape? I mean, patients in the OR, has happened to me a couple of times, I have to admit. You are in the operating room. Do you proceed? How do you handle it? Joshua?
Yeah, again, I sound like a broken record, but I think it all depends on sort of the patient. If you've got an 85-year-old you're going to take a swing for, that might be different from a 40-year-old that's hypertensive. But a lot of times these patients just have an effusion that needs to be drained. So if you can open the chest quickly and slowly drain the pericardial effusion, you might be able to catch up. I think it's key at that point that you have open communication with anesthesia, so they're not bolusing a lot of drugs, because once you open the pericardium, it can be a big problem if the blood pressure is 250. So I think it's definitely worth a shot. I mean, all these type A's represent a catastrophe, and so if you can just prep and drape, forego the lines, and open the chest as quickly as possible.
Of course, you have also the option to put him on fem bypass, particularly if you knew that the patient had pulses in the leg. Chris, what do you think about that situation?
I think that's the one situation where we would do femoral bypass on that one, because that's the quickest way to get the patient on the pump. So
I agree with that.
The operating room, then and they code unexpectedly, they're going to go on pump through the groin, and then do everything that Josh says as well. Then you have time to take a look whether or not there's pericardial effusion. You can open the chest, but that may be the one scenario where femoral cannulation is indicated.
Excellent. We have many more aspects to deal with. So let me go to the next topic, addressing the issue of the aortic root. And let's start from Ibrahim. I mean, the aortic root is 4 centimeters, maybe 4.3 centimeters. It is not 6 or 5.5. And the patient has severe AI. What do you do with the valve? Do you resuspend the valve or you replace the valve? What you would recommend? Uncomplicated type A aortic dissection, patient is hemodynamically stable, there's no malperfusion. What do you do with that?
Yeah, I mean, I think anything over 4.5, we typically would do a root replacement, valve sparing or otherwise. Anything less than 4.5, closer to 4, especially in a larger man, where the index is likely to be low, we would just resuspend. But if the root, if the sinus segments look dilated, thinned out of face, we have a low threshold of.
Would you just preserve the root and replace the aortic valve?
Exceptionally rare, unless you're doing an 80-something-year-old, I think. So.
What about Joshua? Yeah. What do you think about that? So patient has a 4 centimeter root. It's not like 5.5 or something where you say, well, have to do a root replacement, but still there is a significant AI. Do you preserve that aortic root?
Yeah, I would agree. Especially in the younger patient, a Marfan's patient, if the valve leaflets themselves look normal, the sinus segment is sort of free from too much disease or damage from the dissection, then we would either do a valve sparing root if you can, and if you can't, if you have to replace your valve sparing root, if the root looks okay and it's 4 or less, then we would just resuspend and do felt neomedia.
And this is the standard of care, I have to admit. This is the standard of care. But again, I have to caution the participants, if you are not dealing with these operations very frequently and you face that problem in the operating room and the root is dissected and it will require a lot of finessing to fix it. And some of the videos, they show the excellent way to create that neomedia that stabilizes the aortic root. Please don't hesitate to replace the aortic valve. The experts will repair that valve. There's no question about that. But for the surgeons who face that problem in the middle of the night, the best thing that you can do for the patient, and I want to emphasize that, as Dr. Crawford used to say, is to get the patient out of the operating room alive. Then we'll deal with the subsequent problems. But you need to have a patient who survived. We just launched another poll, what people do. And it's very interesting regarding hypothermia. The majority of the people do moderate hypothermia and circulatory arrest and undergrade cerebral perfusion. The difference is quite significant. between deep hypothermia and antegrade versus moderate hypothermia and antegrade. I think we have Derek with us. Derek, we knew that you were in surgery. That takes priority.
Yes. Can you hear me?
Yeah, we can hear you very well.
All right. Thank you. My apologies for being late.
No. We understand absolutely very well. Derek, since you are here, we have asked a number of questions. We have done a number of polling, but forget about what you would do. Okay, we know experts will do more in aortic dissection. What you would advise a person who faces a type aortic dissection in the middle of the morning in a non-aortic center to do for an uncomplicated type aortic dissection? What will be the procedure for that particular situation?
Well, I think less is more. My feeling, even in this healthcare system, is that you are in it for the short term, and our use of more complicated procedures such as frozen elephant trunk and arches is extremely reduced to those patients that absolutely need it. I think that if you look at all the data in terms of survival, etc., it's based upon the first index procedure, and then after that, patients with dissections die from unrelated causes. It's not related to their dissection. If they pass 30 days and they don't get malperfusion, the obvious things are age, ejection fraction, and renal insufficiency. Those are why patients die in 10 years. It's not about their dissection. It's not about their re-op. So we're not aggressive about the arch. We put frozen elephant trunks in for malperfusion, and probably, we lean towards a frozen elephant trunk for young patients, meaning less than 60 years old. In terms of the route, if the valve can be salvaged with just a straight up ascending aorta, hemiarch, no clamp, then that's what we do.
So what you recommend is to do the simpler operation possible, which is maybe an ascending aorta, ascending hemiarch at the most.
Absolutely.
And reserve the more complicated procedures for these peculiar cases with malperfusion, et cetera. Chris, what do you think about Derek's opinion on that issue? Do you have like a 60, 70-year-old patient, stable again? Do you just replace the ascending aorta, maybe a hemiarch, and finish with that and get out of the operating room?
I agree with Derek, and Derek has a great video on CTSNet. I watched it last night. Beautiful video.
Thank you, Chris.
For most of the patients that we see, I think there's three key points. The first is axillary cannulation. The second is aortic valve resuspension, can be done in most patients, including patients with severe AR that is caused by the dissection. And two key points for the valve resuspension is getting those transmural plegited stitches at the top of the commissures and also obliterating the false lumen. The third part of the operation is an open distal anastomosis with resection of all the ascending aorta and part of the hemiarch if you need to get to the primary entry tear. So with those three things, which we showed in our video, I think you'd be able to treat most of the patients who come in with type A aortic dissections.
Josh, what do you think?
Yeah, I mean, I'm not sure we have a quote unquote standard operation. I think the advice that was just given is solid advice. Most people, if you can do a valve resuspension, felt neo media, really get a good proximal. You want a good proximal, essentially, whether that's a root valve sparing or resuspension, and a good distal, whether that's a hemiarch or zone 2 total arch frozen elephant trunk. But I think it's key. I think Dr. Brinster said, you're in it for the moment, which is, you have a catastrophe, get the patient through a good operation, make sure your distal is good, take time on that, make sure your proximal is good, take time on that, and then you can sort of live to fight another day. If the arch is involved, I would agree. I think a more extended arch operation is appropriate, whether that's a zone 2 or total arch, but it's really patient specific.
I would agree with all of you. I think, doing the simpler operation possible, unless you are in a center of excellence that a lot of aortic surgery is being done, maybe it's the best option for the patient and leave to fight the battle at a different time. That being said, I would like Sultan to describe us the neomedia formation. I think it's a very critical part of this operation because it creates substance that you can put sutures without fearing of tearing. How do you create the neomedia? There are many videos. I recommend the viewers to go and watch the videos. They are critical videos. But I would like you to describe to us how do you do that, because I think this is a very important part for the participants and the viewers.
Yeah, Dinos, this was this was popularized by Joe Bavaria and the Penn Group. We really just take a piece of Teflon felt and cut it into a semicircle, and essentially pick all the thrombus and debris out of the false lumen and kind of make what fits in there. So we don't use any external or internal Teflon felt at all, or glue for that matter. All we use is that felt neomedia. And you can use it with a piece of your Dacron graft, or you can use a Teflon felt. Either way it works. And I think, treat it like a sandwich, put it right between your adventitia and intima. And obviously, as long as there's no tears there and it's just dissection, and you're taking a relatively deeper bite of the adventitia and intima and a superficial bite of the Teflon felt that kind of dunks it in there and gives you a nice substance to sew through when you're doing your anastomosis.
Do you use bioglue to put them together, or you don't use any bioglue? What about Derek? Derek, do you use that technique, the neomedia formation?
Yes. Well, we don't always do neomedia. If it's a bad dissection going into the arch, we will put a tongue of felt in there, but we usually do the sandwich in the intima and then outside the adventitia. Sometimes the media if it's a really bad dissection.
No, I think it's a good technique, whichever way you use it, so that you can stabilize the aorta, so you can suture something with substance. Do you guys use pledgeted sutures to reinforce this anastomosis? When and how? That's another important question that I get a lot of questions about the reinforcement of the anastomosis. How do you reinforce it after you do the neomedia, or neomedia is enough? If Joshua could start with that.
Sure, we use the neomedia just as Ibrahim had described it, and as long as you've got a good sort of robust layer of tissue to sew to with native aorta and then felt, we don't use any additional suture unless there's an area that's bleeding. We tend just to rely on that neomedia repair proximal, and if you're doing a hemiarch, distal as well, and then reinforce as needed.
I agree. Let me go to the next topic, and we'll come back again with bleeding. We talked about the standard operation. When you would do some more extensive operations, when you do the aortic arch, what will be a couple of indications that you have to address the aortic arch? And we can start with Derek. Derek, when you will do aortic arch surgery, these are complex patients, and even for aortic surgeons, these operations are very difficult operations.
I agree. I think, we do a lot of dissections, and I would say I've probably done a total arch maybe twice out of the last, 50 cases. And it's usually because I think that the intima and adventitia have torn all the way around the usually lesser curvature, and I'm concerned about hemostasis after that. I think with the frozen elephant trunk, a lot of times those concerns can be obviated, and you can, use a covered stent graft to cover, the left subclavian artery, nail down the intima, and provide, almost arch if you have the frozen elephant trunk and hemiarch sewn together into the lesser curvature. So it's really thin, only for concerns of bleeding, rupture, or when the dissection appears that was, retrograde from the arch downward, and that we're concerned that the integrity of our distal anastomosis is in question. That's when I would do a total arch.
Let me be very specific in that question, and I think I will ask Chris to address that. So you have a tear in the ascending aorta, you open the aortic arch, and in my experience, quite often in aortic arch secondary tears, you see a tear between the left carotid and the innominate artery. What do you do there? You just tuck the tear, you excise the tear. What is your feeling regarding that particular situation?
In that particular case, we're looking to do a total arch. I think there's two indications or two recommendations where surgeons should seriously consider doing an arch operation. It's not mandatory, but consider it. Is that if there is a tear in the arch which cannot be resected with a extended bevel. So you can't get it all out with an extreme bevel on the underside of the arch. And the second recommendation is probably if the patient has some sort of malperfusion, whether that's cerebral or downstream malperfusion, and you're not quite sure that you're going to get established true lumen flow. I think that's an excellent case to do an elephant trunk procedure in addition to your arch operation.
Again, I have to emphasize to our viewers, these are not your typical situations. These are more extreme situations. And, if you face this unpredictable situation, you have to do the best you can. But I agree with both Derek and Chris. These are the cases that you may need to do a little bit more of extensive surgery to fix the problem. These are technically complex operations. They are not easy operations. Let me get some of the questions here. Patient who had previous coronary artery bypass grafting comes a few years later on with intramural hematoma. Ibrahim, what do you think? There is no flow into the, false lumen. Do you wait it out a little bit? What do you do?
Yeah, I think we've learned a lot from our East Asian colleagues about this. I think they manage this very differently than I think American surgeons do. We have become much more conservative about these patients. So it depends on the thickness of the hematoma. It depends on, typically these patients don't have malperfusions. And we admit these patients and repeat a CT scan in 24 hours. I mean, especially it's a redo, IMH, repeat a CT scan if the IMH thickness, enlarges, if patients have persistent pain, there's some evidence of malperfusion, AR, et cetera. I think those are the reasons to potentially go after. Or if the patient has an aortic aneurysm to begin with, which is actually relatively common in these redos when they come in with IMH. So those are kind of, our go-to moves.
So you will wait it out a little bit. You're not going to jump, to do an operation immediately. Josh, what do you think about that scenario?
Yeah, I would agree with what Ibrahim said. I think, barring malperfusion, a gigantic ascending aorta or a hematoma that's greater than a centimeter in an elderly patient, redo, largely asymptomatic, I think it's totally reasonable to wait 24 to 48 hours, re-image, see if the IMH has changed or if the aorta has changed at all. Maybe there's some kind of dynamic process that is now changing. Close observation, ICU though is critical.
That's a reasonable approach, particularly in elderly individuals. And, you can always go back. I mean, there is a lot of scarring, so there's no pericardial space. Usually there is the blood flow through the coronaries prevent you from left main dissection. So you have a lot of safety here. A lot of questions that I'm getting is two questions. Number one, what do you think about glues, like BioGlue, a variety of glues that they exist? What do you guys think about that? Let's start with Roland. What do you think about BioGlue? Do you put BioGlues after you finish? Do you recommend that?
No, I don't. The only place I put 2 drops of BioGlue is when we do the neomedia felt, just like Ibrahim described. The only difference is, I learned to do this with putting a couple drops of BioGlue inside the wall of the aorta, so there's no glue exposed outside or inside the aorta. But, we don't. We are afraid that the BioGlue actually can basically hide the bleeder that might show up later as a pseudoaneurysm.
Yeah. What about Chris? Chris, what do you think about that? Do you use any BioGlue around the anastomosis or any other glue?
Well, I think the biologic glue or the glutaraldehyde base adhesives, like you, I use them for the root reconstruction. I use it for when I want to obliterate the false lumen. So I put that in between the layers. I don't use any felt in between. And I think there's a couple key points to using the biologic glue. And the first is to use very little. Roland said to use a couple drops. I think that's a good way to think about it. And make sure you control that glue. I saw that in your video, Dinos. You can't let that glue come out. You can't let it go down the coronary arteries. You can't let it touch nerves. But if you can control the glue, use very little, it's very effective in obliterating the false lumen in the aortic root during your valve resuspension.
I think I agree with you, Chris. I think that's a critical point in the sense that this little glue can, create truly a media. And you have the intima, the adventitia attached. That tissue is very leathery. You can put the sutures through, it's very strong tissue, which comes to the point, what do we do to prevent bleeding? I mean, everybody knows that aortic dissections are prone to bleeding, and yes, we have physiologic issues, but let's talk about technical issues. And let me start with Ibrahim. Ibrahim, what is your technique to prevent bleeding from the proximal and distal anastomosis? Besides putting that piece of Teflon felt in between, are there any other techniques that you like to use under those circumstances to prevent bleeding?
I think the simplest thing that I do think makes a big difference is to intussuscept the graft inside the aorta. I think if you intussuscept the graft nicely, and I think this is, when you're walking, when you're fellow or in the operation, if you're on the left side, I think really to park that graft inside the aorta. And I think that makes all the difference. And on the topic of glue, I've learned to hate glue after doing a bunch of redos for pseudos and otherwise, and it just makes it very, very, that's where the hate comes from. But I personally don't use that, but that's really what I focus on. I really focus on making sure that the anastomosis is truly intussuscepted and checking it before you come off. Invariably, some patients are going to have weaker tissues than others, and invariably there's going to be some bleeding, but I think that's the one thing you can do to really help yourself.
Derek, what do you think about that? What do you do? What is your technique?
Yeah, so, I think Ibrahim bring up a good point about reops and glue. It's very painful, but what I hate even more is post-op hemorrhage. So I think using the little bit of glue, making sure it's not, a gallon or a bucket of glue at the root, I like it. So that's one of the methods to prevent bleeding. We use, in our video, we commented on it, but on a lot of our reops and our major cases, we give 4 of FFP when we're down to 2 liters and it looks like we're going to separate successfully. I feel that it prevents kind of this post-operative flood of blood products, going to the patient, and, you might have RV distension or something like that. And then we typically give 10 units of cryo and a bag of platelets, see where we kind of end up. And then we usually give FEBA. That's our preferred, method. And we give the FEBA, I tell the anesthesiologist to give it over 30 minutes so we kind of don't have a pendulum swing to hypercoagulable state. And then we see where we're at. If we got really bad bleeding, we'll give a touch of factor 7 or another dose of FEBA after that. And all of these, we try and give over a very prolonged time, because I'm sure every institution has stories about where these activated products have resulted in, intracardiac thrombus or something like that. So we give it over a longer duration as best as possible.
Chris, give us a little bit your algorithm. What do you do under those circumstances? So we're talking, and I want to hear both regarding the technical aspects, as well as, for example, you use factor 7, as Derek said, or K-Centra. These are very powerful coagulants that can be helpful. How do you handle it?
I think for the issue of bleeding, this is where surgical technique counts. So what I do is I give the residents a 4-O-Proline. Typically, I use a 3-O polypropylene for my aortic anastomosis in elective cases. And I have the resident take time making those bites. You're really only doing 2 circles, and you have to wait to cool and rewarm anyway. The bites have to be perfect, 90 degrees through the plane of the aorta, no torque, suture holes matter in these cases that will determine how long it takes you to clean up afterwards. We also take advantage of the fact that we have protein concentrate complex now. So there's several on the market. I think those are very effective. We give those very, very early in place of giving large volumes of plasma or cryoprecipitate. So I think the PCCs have been a great advance for the management of bleeding in type A aortic dissections.
No, I agree with you, and I want to point out you talked about the technique, and I think that's a very important part because the way that you put the needle and the way that you turn the needle, you can make the hole smaller or bigger. So I fully agree with you. I think it's a very important part as to how you're going to fix it. Roland, what do you think?
I totally agree with everyone, Ibrahim, Chris, and Derek. So I think it's absolute perfect technique, no torque, no tearing. Every single stitch has to be perfect. It doesn't matter how much time you take, because that's what makes the case basically. And then at the end, over time I learned that really giving FIBA early on makes a huge difference. It's actually like magic, difference it makes. And it's very relevant, especially for patients. More and more patients now show up and they have NOAC in their system.
That's correct.
I think it's very effective for these patients as well, in addition to the monoclonal antibody. But many times FIBA really is a lifesaver in these cases.
Ibrahim, what is your feeling about bleeding, and how do you prevent it, both from the technical perspective, meaning pledgeted sutures, bioglue, etc., as well as from the physiologic standpoint, different coagulants like Kcentra or factor VII?
Yeah, as I mentioned, I think the technical part is the most important part. I think intercepting your graft and the anastomosis is absolute key. Using appropriate, neomedia always helps. And typically what we do, our cocktail is, if there is excessive bleeding after protamine, we give 10 of cryo, 2 bags of platelet, and a milligram of factor VII. I have used Kcentra twice, and I've had horrible experiences both times. But I think I think what Derek pointed out, giving it over time, I think makes a huge difference. But that's our standard cocktail if we see excessive bleeding. We don't necessarily use it in everyone. Typically, we use it based on our data about 30 to 40% of the time.
Joshua, what is the pen way of dealing with that problem?
Well, I think these guys have really hit on the head. I agree with intussusception. Choosing an appropriate size Dacron graft, undersizing can have its problem with, creating flutes if you're creating torque in the tissue. And then I agree. I think Ibrahim had said this earlier, test your proximal. We use a Verdi needle, and you can give plegia down the root, clamp the top, and it's you can get a pressure of 200, 250 and see if you have any major holes that need additional sutures. You're going to have needle hole bleeding because it's super thin, obviously, but it'll give you an idea of what your proximal looks like. If you preserve the root and you come up bypass and you have to start putting repair stitches, that's when things get sort of hairy, and you can sort of lose control of your proximal anastomosis. And then we have a sort of a graduated approach to resuscitation. Really big on replacing fibrinogen losses and platelets due to the circ arrest. And then if we need to, you can give factor VII.
Listen, time is already 11:59, believe it or not. We had a wonderful discussion. I would like to thank you personally, Josh, Ibrahim, Ronald, Chris, and Derek for, number one, coming here today to talk about your experience to a lot of cardiac surgeons who I hope that they get a benefit from that discussion, particularly when they take care of these complex patients. And again, I would like to thank Joe Dunning, who started this wonderful idea, Catherine Joyce for making that happen with her staff, as well as the sponsors that they sponsored this wonderful event. And Jackie, my nurse, who's sitting next to me. Without her, forget about that. Nothing would have happened. So again, I would like to thank everybody for participating and looking forward maybe to a next one. Thank you very much.